We might make a start. So welcome everybody. This is the first webinar of the Wednesday Webinars for Wellbeing series, which is being coordinated by the Interagency Standing Committee for MHPSS Reference Group, specifically the Child and Family Thematic Group. So this series is going to, across the year, we'll have 6 webinars highlighting different topics in child and family mental health and psychosocial support in emergency settings. So we're really excited for this webinar series. It's going to be a collaboration between different agencies for each topic, bringing together different experiences and discussing also with the attendees. So today is the first webinar series, and coming up in April, we have a webinar on sport and MHPSS for children and youth in humanitarian contexts. In June, we have promoting adolescent and youth mental health and well-being in a changing climate. And you'll need to stay tuned for the rest of the webinars coming up in the second half of the year. But today, I'm very pleased to introduce the first webinar, which is promoting early child development through MHPSS interventions within the first 1,000 days. We have our 2 presenters, Ruth O'Connell, Regional MHPSS Specialist from UNICEF IAPR, and Swan Fan, Mental Health and Psychosocial Support Specialist for Action Against Hunger. We also have moderators joining us, Meenakshi Dogra and Ulzi from UNICEF, and we have Karine LaRoche from ACF, and I'll be here just supporting the overall running of the webinar and the Q&A. So I will now hand over to Ruth to start us off. Oh, sorry, forgot to mention, if you have questions, please use the Q&A function in the webinar. This helps us to not lose your questions in the chat in case the chat gets busy with other things. So the Q&A function should be at the bottom of your screen, and you can type your questions there. Over to you, Ruth.
Hello, everybody. It's a pleasure to be here with you all. So we'll just go to the next slide where we will see what's on the agenda for the webinar today so that you can be thinking about this as you go through. And if we haven't answered or addressed any of the questions that you have, you can type them in. So I'm going to turn off my video now so that I can present more easily for you. So today we're looking at promoting early childhood development and mental health and psychosocial support. We're going to be looking a little bit at the nurturing care framework and specific vulnerabilities that affect this target group that we're talking about, which is mothers and babies. Then we're going to go, excuse me, then we're going to go through some experiences and some case studies from ACF's work. They've done extensive work on this, so that's going to be a significant part of the webinar. And then we're really hoping to have a very nice part of time at the end where we can really address the questions that you may have, and we can go deeper into some of the topics that are of interest to you. So we're going to start with a little quiz to get everybody in the mood. So the first question, what age range does the first 1,000 days cover? So the answers are going to come up, so you don't have to write them in the chat, but have a little think, and then the answer is 2 years. The next question on our quiz, just to get us in the mood, is do the first 1,000 days start at conception or birth? So have a little think about that while we wait for the answer to come up. And the answer is conception. Okay, then the next question. What are the 3 stages of the first 1,000 days? And the answer to that question is pregnancy, infancy, and toddlerhood. The next quiz question is a true or false statement. Attachment parenting means that you should carry your baby all the time. Is this true or is it false? It's false. Okay. Then the next question and the final question is at least 43% of children under 5 are at risk of not achieving their full developmental potential. Is this true or is this false? Let's see what the answer is. True, unfortunately. So let's move on to the next slide now. So basically, we just wanted to set the scene a bit and look at mental health across the life course so that we can really pinpoint this early stage that we're talking about in the first 1,000 days. So we know that mental health is influenced by protective and risk factors. And given the implications of the risk factors on early childhood and development, it's really essential that we do intervene early in order to promote mental health and well-being. So it calls for a combination of interventions across different settings and involving other sectors beyond health. So one really interesting thing, I think, for us in this slide is that when you look at the risk factors and the protective factors, you can really see the entry points for different sectors where they can come in, which again really speaks, I think, to this multi-sectoral approach. So we know that, for example, in preconception, peri and postnatal, and in infancy, MHPSS support for parents can mitigate the impact of adverse family circumstances, the ones that really result in children experiencing early life stress. And then we also know then that leading on from this, childhood and adolescence are critical stages, and interventions that reduce family conflict, bullying, for example, and support life skills can protect against mental health issues during this stage and well into the future. So if we go on to the next slide, this is just to talk about why mental health and early childhood development. Well, we know that in the first few years of life, more than 1 million new neural connections form every second, and that half of all mental health difficulties start before the age of 14. So again, this stage of a person's life is absolutely huge, knowing that if there are significant problems during this time frame, it's very, very hard to recover from that as you grow older. And this can have implications in terms of forming relationships and entering into the workforce. And we know that our definition of mental health, it's a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to his or her community. So this is really important, therefore, that we do look at the social determinants of mental health, acknowledging that they are very important during the first 1,000 days. Social determinants particularly are important during developmentally crucial stages, and such as violence, harsh parenting, or neglect. So it's very important for children, babies, to have this positive social interaction. And then we know also from studying brain development and the impact of prolonged stress leading to toxic stress, it's very important that this stage of life is really considered very carefully in our programming. So if we move on to the next slide, we just wanted to really, as well, I suppose, given that we are looking at this as a multi-sectoral piece, we know that experiencing an accumulation of different risk factors is a strong predictor of poor outcomes, so that we need to be identifying children who face a number of different risk factors. This is better than identifying one single risk. So again, we need to be really looking at all these entry points, because we know that systems should not be responding to a single risk in isolation, but it should understand the multiple risks faced by children and caregivers. And we would really advocate for services to work together to share information, plan and implement together. And I think, as we're all well aware, that basic needs really must underpin all interventions. So in the next slide, again, I suppose a gentle reminder for us all to really look out to make sure that our programs are inclusive, and that some mothers and babies are more vulnerable than others. So we know that single parents can be more vulnerable. We know that pregnant adolescents or adolescents who are parents are more vulnerable. Mothers and babies in conflict settings. Women and girls pregnant as a result of sexual violence, or babies born as a result of sexual violence. Mothers and babies in polygamous families. And mothers or caregivers with a disability, or babies with a disability. So then, as we move on then to a very brief introduction to the nurturing care framework, because I know Suan is going to be going into this in greater depth. This is really important because it again highlights the need for a multi-sectoral approach, which includes MHPSS, because we have all these entry points, including good health, nutrition, responsive caregiving, safety and security, and opportunities for early learning. So when we consider the vulnerable groups that we really want to capture and we really want to engage in our programming, this nurturing care framework is particularly important to consider when we're working with them. So I'm going to hand over now to Shuana. Thank you very much for your attention.
Thank you, Ruth. Good morning, good afternoon, everyone. So I will present on behalf of ACF some of the intervention, so you have like a better idea and more concrete example of what Ruth just introduced. So ACF has like MHPSS interventions along with as a multidisciplinary approach along with food security, livelihood, WASH, but also health and nutrition. And here the focus will be the integration of MHPSS within health and nutrition program. As Ruth mentioned about all the vulnerable groups, the core target population that ACF work with are especially mothers and babies, so under 5 and under 2 in emergency settings. And the aim is to improve both the prevention and the treatment of acute malnutrition, because in early childhood and specifically within the first 1,000 days, the nutrition is very important for the development and the growth of the child. So we do have so improvement of prevention, treatment of severe acute malnutrition, but also working to improve the mental health of caregivers and particularly of the mother. And different experiences, some research as well did show that combined intervention of MHPSS and nutrition do improve child growth and development. On the next slide, I will show here the ACF approach was based on the childcare practices using the UNICEF framework of malnutrition and using the definition of Engel's childcare practices, which are the behaviors and practices of caregivers. So caregivers in general, including mothers, siblings, fathers, and extended families that provide food, stimulation, and emotional support for the child's proper growth and development. So you can see here on the different icons, there are like 6 big childcare practices, from care for women, which is the perinatal period, including pregnancy. So the care for the mother is very crucial, along with psychosocial stimulation, food preparation, all the IYCF, infant and child young feeding is very important, as well as hygiene. And then it has been translated, this model of care has been translated into the nurturing care framework. And you can see that all those components are there in the different component of good health, adequate nutrition, responsive caregiving, safety and security, and all the opportunities for early learning. And we have here the recommendation from the WHO, meaning that all the good care practices here that help the child to grow and develop in an enabling environment with all the parents to feel secured and loved and when they meet all their needs. And here to show you an example of the intervention that ACF does in emergency settings to promote so early childhood development. There is a manual that we have developed called Baby Friendly Spaces, that to implement this kind of intervention either in camp settings for displaced people, refugees, but also it can be used in health settings and in form of like baby-friendly corners. So the main objective of this intervention is to care for, so mother, caregiver, to help them care for their children. And it's like a safe place where they can share their experience and where we have like different activities. So here, using the color coding and the nurturing care framework, you can see that we do have like a multiple approach and using all the different components of the nurturing care, from breastfeeding counseling through support to the mother through relaxation exercise and psychological support, and then some play sessions or massage or discussion to improve the child and mother interaction and promoting responsive caregiving and early learning. In the next slide, I will show you an example of a research that has been conducted in Nepal to show that the combination of both nutrition and psychosocial intervention on the treatment of SAM children showed like improvement. So here, there are like five sessions of psychosocial support and activities that has been implemented every 2 weeks and for a duration of 30 to 45 minutes each session. And in each of the session, in the next, please, there is, it is conducted by a psychosocial worker. And here it's an example to show you in detail how a session is conducted with the psychosocial worker and who accompany the mother through like different stages from like the different key messages that are important to keep in mind, and through different activities. So here in the play session, how to play with the child, how to interact with the child. And so from these outcomes showing that it was successful, we did adapt in the project in Burkina Faso. We did adapt the FUSAM protocol to be used in mobile clinics and inpatient facilities within a GAC project for the last 2 years. So it has been implemented in 2 mobile clinics and 2 inpatient facilities. You can see that the time frame is different. So it has been implemented through 5 sessions within 3 months in mobile clinic versus within 1 week up to 20 days, depending on the stay duration of the baby in the inpatient facilities. And for each sessions, we received 7 to 8 dyads, meaning like the couple of mother, caregiver, and the baby in each group per session. And each group are facilitated, as you can see here in the picture. So there are 2 psychosocial workers who are supervised by a psychologist to conduct all the sessions. And so during those activities, we have some indicators that are measured. So, for example, well-being, the child and mother interaction, the knowledge in childcare practices. So over the 2 years project, we did set up 13 mother-baby spaces within the mobile clinics and IPF, and we received over 5,000 mothers and their babies. I will show you some results in the next slide here. So those are the preliminary results from 2023. It's like only an extract because we had some issues in data entry. So I show you here an extract from 171 dyads for the child and mother interaction. So we did use an observation grid that has been administered pre and post intervention. And so you can see here for both the child and mother interaction that it has increased in terms of emotional or verbal, visual, and body interactions, that all those stimulation has increased and improved their interaction during the activity, as well as the mother well-being using the WHO scale, that there has been an improvement between pre and post intervention. And the level of distress, we did use like visual scales. So the first one with the stone is the level of distress of the mother with a self-evaluation. And then we did ask the mother how she feels about the well-being and the distress of her child using like the other scale, the suffering scale, for her to assess the level of distress. And you can see here for both the mother and the child reduction post intervention. In the next. This is another implementation project that I present on behalf of my colleague Elisabetta. She has implemented in Central African Republic a protocol using emotional stabilization for mothers and babies. So in that one, the objective is to support maternal mental health and promote and improve responsive caregiving by reducing the distress of the mother and to reduce the impact of maternal distress on the baby. In conflict settings, both like any adults and in particular vulnerable women during a perinatal period or during pregnancy are at risk of increased depression and therefore not being in like a good condition to take care of themselves, but also to take care of their babies. So in this protocol, what has been used, it's a daily participation where we organize like 4 group sessions. And so we have like the group of pregnant and lactating women to do all the exercise. And then when possible, we tried also to have like lactating women group with their babies. So to have like a specific exercise with their babies. So here again, activities are conducted by psychosocial workers, and they are all supervised by psychologists. In terms of like one session, it's you have like opening session rituals, like they can sing, they can pray, they do introduce themselves. Then we have psychoeducation session activity, followed by stabilization exercise, and we close by some rituals as well. I will show you some results of this intervention. So here to measure the psychological distress, we did use the HAD, which is the anxiety and hospital and anxiety and depression scale, as well as the PCL-5 and the visual scale here using the subjective units of disturbance. So as you can see as well here, for the PCL-5, there is a reduction in terms of post-traumatic stress disorders. And for the HAD, so the first one is about the depression one, we can see a reduction, as well as HAD for anxiety has been reduced. And the distress also from the SUD, you can see that across the 4 sessions, we can see a decrease of level of distress. Yeah, so overall, The main challenges here, because we work in the emergency settings, it's about timing. So it's a very short intervention. So we can see some changes, but over the long term, it's difficult to have like more activities and to see the outcomes. The fact that our population, our beneficiaries are very mobile, related to the settings and of the conflict, they have to move from one place to another. So sometimes we have to face loss to follow up of beneficiaries. Access to health facilities or mobile clinic and security issues also restrict all the movements and intervention. In terms of monitoring, it's one of the main challenge also, and some of the measurement tools. So for example, how to measure early childhood development. It's sometimes challenging to find like the appropriate tool to measure that. And then all the cultural adaptation. So it showed that we do need to adapt all the tools, the questions and the activities. But overall, thanks to this cultural adaptation, there has been like good acceptance of the different protocols and intervention that we have implemented so far. And we did observe like an interest and a real engagement of the beneficiaries through those activities. Like while usually they do have more interest in like food distribution or in kinds, and then here they were really interested to come and then attending those activities of group discussion and for example relaxation exercises. We did observe also like less dropout and loss to follow up and better retention in care. And of course, like with the different scales that I did show you, we showed and observed and improved in well-being and as well as knowledge and care practices. I will hand over to Ruth for some take-home message.
Thanks very much, Suan. So yeah, we're coming to the end of the webinar now, so that we've got a lot of time left for questions, but we just wanted to finish with, I suppose, some recommendations or reflections on really what constitutes an effective MHPSS and ECD intervention. Well, so what we would advocate is that it's facilitated by health and nutrition or community or youth workers or psychosocial workers who are trained in the identification of mental health vulnerability and signs of distress in parents and caregivers, which includes, I suppose, knowledge of long-term and short-term reactions, particularly in conflict or emergency settings, and that we would advocate that everybody, all personnel, are trained in psychological first aid, staff and self-care, and referral systems to other services where they exist. They can be mobile or static, housed in a variety of different contexts like nutrition centres, even vocational training centres or hospitals and primary health care, and that they really embed the creation of strategies for the voice of the caregiver to be sought and heard, including the most vulnerable, and that we can identify multiple opportunities for mothers and babies to access support depending on the needs, which are cohesive, holistic and coordinated, and that we can facilitate specialist MHPSS support if appropriate in a way which is not stigmatizing and carried out in conjunction with other services, including peer support. And I think this is particularly important when we're looking at the groups experiencing specific vulnerabilities that we mentioned earlier. And that the effective MHPSS and ECD interventions should provide opportunities for parents to receive attachment support, parenting support, and opportunities to learn and practice self-care themselves, as well as caring for caregivers. This should really be a key part of any of this work, is that the caregivers themselves are supported to look after their own mental health, and that they're carried out in collaboration with other interventions, so that they're not carried out in isolation. Because we know that health system which supports well-being and agency will also have a positive impact on health promotion and adherence to health-seeking practices and behaviours. So the more people are listened to and the more they can participate, then the more likely it is that we will have good results to our programmes. So the next slide is just references that Siwan and I used in this presentation. And it's now time we will be sharing this presentation with you. So I'll hand over now, I suppose, to Felicity, who will organise the question and answers. Thank you very much.
Thank you so much, Ruth and Siwan. And thank you everybody for joining and your participation in the chat and the Q&A. It's so nice to see so many people joining in from so many different places and organizations and backgrounds. So thank you. We have a few different questions in the Q&A. I think some might be kind of quick clarification questions and some a little bit broader. So I might start with the clarification questions. So Godfrey asks, just for clarity, this is just one, were you using EMDR as part of the emotional stabilization for mothers and babies intervention?
No, here it's really for like emotional stabilization. So we did use the techniques of stabilization in the EMDR therapy. There are like a whole different processes, but we did use only like the emotional stabilization aspect. So meaning like breathing exercises, visualizations, like feeling all the contact of like, I don't know, like what you hear, what you see, very like stabilization. Yeah. I don't know if that answered the question.
Thank you. Another question was just what tool or resource was used with women in CAR by ACF for the sessions for emotional regulation? And is it a public resource or something developed and adapted by ACF?
So it is something that was adapted by ACF. For now, I think Elisabetta is finalizing the protocol. The resources were still it's still under construction. I would say we started doing it, but it's still at a draft stage, and we will probably share it at a later stage, but not now. But then for those exercises, I think that you can find some of those on the internet, and then WHO, like for example, in the Self-Help Plus protocol, there are some stabilization exercises, or from the psychosocial support manual that was developed during COVID, there are also some of the exercises that you can use.
Great. Thanks. And Katerina Godfrey, feel free to let us know in the chat if the question hasn't been answered sufficiently, but thanks, Siwan. We have a question from Alexandra. What lessons have been learned from adapting the FUSAM protocol to Burkina Faso?
So the main lesson learned is that it's working, that people are happy to have this combined intervention, both within mobile clinics and the inpatient facilities. So, and particularly in inpatient facilities, because it's extra staff, and we have like ACF staff working in those in the inpatient facilities, and the fact that we did interact, listen to the patients, they were more open and engaged, and they could find someone to talk to about their issues that they did face with the baby in with their babies. One of the main challenges, of course, is when they come to the IPF, is that they stay for some time. to take care of only one child, and then the rest of the family has to stay home. So usually one of the risks is the mother and the baby leaving back home for the mother to take care of the rest of the family. So here we do provide also some support to make sure that the caregiver is able to stay and take care of the child.
Great, thanks. We have another question from Don McPhee, and this one, I guess it can be for all of the speakers and the other colleagues online. So John's just interested in the process for culturally adapting or adapting interventions to specific cultural contexts, which we know is a common thing across all MHPSS interventions, but it'd be great to hear
So
this.
it's really participative approach and kind of a learning by doing process. Huh? So it's really about the acceptance and acceptability of the different tools. So usually first it's first about the translation of some cultural, to adapt to the cultural setting, like some of the terms that are being used to be translated in the proper local languages. Of course, working with psychosocial workers that do speak the language. And then for some exercises, for instance, with the stabilization exercises, for instance, like all the breathing exercises were done when people are sat, yeah, on the chair. And because when people lay down, it's culturally not appropriate because it means many other things that that are not appropriate. So that's why, like, this kind of cultural adaptation. And the best is, of course, to ask the people we serve to see what is the best way and what suits them best, most in terms of activities.
Great, and there's a question that's coming up a few times, and it's just about different, in some contexts, like in Central African Republic, there are people of different origins and religions, and there's been a few questions about whether this poses any challenges for those delivering the interventions needing to adapt to multiple.
Yeah, so for this intervention adapted in CAR, I would, I mean, it's not the country that I work with. So Elisabetta, who is not here, would be the one best to answer. But as I can see in other countries where I work, and there are also like different ethnicity, that it's something that you have to take also into account. But usually, it did work well when we put them in groups. So far, we haven't seen any major barriers. And if it is a big problem, then I guess that it is addressed by maybe separating, like doing different groups.
Great, thanks. And participants, if you have experiences yourselves from adapting to different contexts and to different populations, also please feel free to share in the chat. We'd love to hear from you. Another question. Oh, sorry.
No, please
another
go ahead.
question. Another question that also has come up a few times is just this question of father engagement. So this is often a challenge when we're working with family interventions or parenting interventions. So I'm really interested to hear from you and others as well, if this has been a challenge and how it's been addressed.
Yeah, so actually that was an anticipated question. So if you go further down in the slides, we do address next. No, it's the last one, I think. So of course here we chose to present the main intervention that we do with mothers, because they are the main caregivers, and in the real life it's mainly the mother that is involved in the care for the child. But of course this cannot be done without the involvement of fathers and extended family. Like sometimes it would be like the grandmother. And then, so here, as you can see, we did develop also some protocols. So one in Sierra Leone, for example, to conduct father support groups. And then we have like different activities in the father support groups where we discuss with the father about how to take care of the child, like the importance of nutrition, the importance of supporting the mothers, and so on. And then there is another also protocol that has been developed also by my colleague Elisabetta about parenthood, where also we discuss about with men about anger management, for example, about domestic relationship and so on, and for them to find, for the father and man to find their place and the role in the family.
Great, thanks. And again, if anyone has other experiences from your context, please do feel free to share in the chat. It would be great to hear from you. There's a question from Lynn Jones, and I see maybe it's in some of these sessions, but she's just asking about in some of her programs, programs would include sessions on recognizing childhood illnesses and the importance of vaccinations and so on, as well as long-term physical health for the mother. And Lynn's just wondering how this is incorporated into ACF's sessions, or if it's incorporated.
Yeah, sure. So here actually, so because it is integrated within the mobile clinics, we have like in the care pathway, the mother and the child goes for the health and nutrition services first. So they are already like a triage and then screening for if they need any vaccination and any healthcare. But then we do have also, like in terms of group discussion about childcare practices, we can also have some discussion around promoting, like vaccination or prevention of health, and then these because we work with the healthcare workers within the community. This is this promotion of vaccination and IMCI is really done by the community healthcare workers. Yeah.
Great, thanks. There are a few questions just about the criteria for selecting the participants in the program. So for the mothers and caregivers and the babies, if they were screened in any way, if there was only people meeting certain risk criteria.
So because we work in mobile clinics and integrated in the for the screening of severe and acute malnutrition or moderate acute malnutrition. So the entry point is through the health and nutrition screening. And then for babies and mothers that are identified in malnutrition, they would be referred to the psychosocial worker to work on the psychosocial intervention. But then for those who are detected as with no malnutrition, we are not doing nothing, we are doing the prevention aspect. So they are also referred at some point, and there are group discussion and prevention that is provided during while they are waiting in under the tree or in the health facility.
Great, thanks. There's questions still coming in, so I think we've got a lot of questions.
Okay.
From Godfrey, just a question about if there was a specific protocol for the stimulation aspects that you mentioned earlier.
So in here, we can share with you. There is in the manual, integrated manual, we have like for the stimulation, like baby massage, and play sessions where we work with different toys. There is also, and I think it's still it has to be finalized, but we have developed also a manual on psychomotor stimulation, like for rehabilitation, more specifically. But it hasn't been officially released yet. And of course, Karine, feel free to jump in if you want to complete any of the questions. If there's anything you would like to add, Karine. Okay, thank you.
And
yes.
so if I'm just thinking, if participants like today's participants or others that are watching this later are interested to access and learn from the materials that ACF has used, can they get in touch with you?
Yes, of course. I think in the reference, what I can do, because the problem is there are some of the manual that are available online. The others are online, but internal in the internal website. So, but yeah, I can share. Maybe I can share later on with you, like electronic copy of the different manual that can be shared. Yeah.
Great, yeah, because it's so nice to see these amazing different packages and the good results that you had. So I imagine there might be interest from others to build from the great work. Okay, let's open it up to Ruth and others as well. There's a few questions linked to scalability. So just recognizing the constraints in public service, health workforce, and also we know in social services workforce, and limited availability of psychosocial workers. So there's a few questions just about whether the intervention is kind of resource heavy and needing a lot of materials, and just what are the potential pathways for taking, I guess we can look at ACF's interventions, but also other ECD interventions. What are the kind of challenges and opportunities for taking these to scale, not just in humanitarian settings, but other settings? The big question.
Shuan, do you want to answer that, considering you're talking about these programs already? Like, was the intervention that you've referred to, were they heavy to set up? I mean, certainly with the ECD programming that UNICEF does, which works differently to ACF, although they do complement each other, we would work in primary healthcare, in education, and usually through existing structures that exist or existing mechanisms, particularly through frontline workers. We don't take the same medicalized approach to the work that we're doing, but we would work mainly through frontline workers, community workers, and that kind of thing. I don't know, Shuan, do you want to come in from your perspective from ACF?
Yes. So here, in terms of scalability, what I would say is, so because here is really in the context of emergency. So we are definitely, like in most of the situation, in the substitution mode, where we go, where all the health services are disrupted. But we tend to localization. So we would work in partnership with like local organizations, where we would transfer all the skills and then the knowledge, and in capacity building the local organization to do it. And in terms of exit strategy, and that would be one aspect with local organization, but also in the health system strengthening, we would work also with the health workers in primary healthcare when it is functional, and in the IPF as well, to train the health staff to provide all the services, all these activities. So they are really interested, but of course, then it's a matter of time because it adds up, of course, in their ongoing workload already. And we do work also with community health workers. So beside all their activities within the community, going through distribution of mosquito nets, vaccinations, promoting, hygiene and so on, we also sensitize them and then encourage them to promote all the childcare practices and doing when they do home visits also to pay attention to those aspects. And as you can see, like father support groups or mother support group is locally led and community led. So we do identify, strengthen the capacity of lead mothers, lead fathers, and then, hopefully for them to continue doing the activity. Yes. Thank you.
Thanks. And Ulsi, please also go ahead.
It's very interesting discussion, and we really think mental health support is needed for parents and caregivers in ECD. In the APRO regional office, there are several countries that are implementing parenting programs in ECD. Like 6-7 countries we have, and I'm thinking to share these resources with these country offices at the regional level among the ECD colleagues, and it's good if we can integrate some of these components and supporting mental health of parents and fathers in our parenting programs. Especially in Mongolia that I am from, we do parenting programs also in Mongolia country office, and really also looking forward to learn more and implement more mental supports for parents and caregivers. Thank you.
Thanks so much. And just on also on this on the question of oh yeah, sorry, yes, Quiva has just clarified. So Ulzi is from the East Asia and Pacific Regional Office of UNICEF from the ECD team there. Just clarifying our UNICEF acronyms. On the question also of scale, I know that ACF has been involved in a lot of research initiatives, including implementation science. So Karina, I don't know if you'd like to add anything also about the implementation research and what you're learning about taking MHPSS interventions to scale. Sorry to put you on the spot.
Sorry, me, I can't really hear you, sorry.
Oh, Karine.
Okay, sorry.
Can you see me? Can you hear me? Yeah, good. Okay.
Yeah.
Thank you, Felicity, for asking this question. As you could see during Swan's presentation, we try as much as we can to measure different indicators to really understand what is the effect of our interventions on the child and the caregiver. For the FUSAM study, what we actually did, we did this protocol because we really wanted to see the effectiveness of those interventions. The protocol is based on many years of field intervention that ACF has implemented and promoted in various contexts. So basically, the results were really astonishing because we had those 3 groups, and one group had only nutrition treatment, the other group had nutrition treatment and psychosocial intervention, and we also had added to those 2 groups a reference group in the community. In most of those contexts, we have no references on what is the trend for child development, which is really something we would need to explore more. So what we found out is that those children who actually had benefited from the psychosocial intervention, they saw their development increasing, not as much as in the reference group, but more than in the group who did not receive the intervention. So I think I would really advocate for measuring these the child development, including social problem skills, motor growth milestones, communication skills, because we've got really, really low information about what's going on in the different contexts. And those measures are not necessarily taken at national level. We need to have those references in each context where we work. So it's not easy. It usually requires some, very heavy trainings, but there are still the measures out there that can be used. And I think this will be also a way to scale up those interventions as soon as we will be able to show more the effectiveness of the intervention and the added value, the positive impact on child development, then we will be able to scale it up more, I think, from research perspective.
Excellent. Thanks so much. So we've got just 3 minutes left. There are a couple of questions kind of linked to the same theme, just around, a common thing, especially when we are working in emergencies or, context, as you mentioned, with a lot of challenges and risk factors for mental health, social determinants for poor mental health. We often have families that have a lot of unmet basic needs. And maybe requests for other resources, expectations of receiving material resources as well with the interventions. So there are a few questions just about how you manage that when you're working with vulnerable mothers and their babies.
Yeah, as much as we can. No, so actually we try to refer because we cannot cover all. The idea, and that's why one of the major things that we do when we identify the area of intervention, it's in coordination with other existing, stakeholders working already in the area. So it's a mapping of services. So what we do usually is to refer depending on the identified needs. And because we usually try to work in a multi-sectorial approach. So beside health, nutrition, and MHPSS, we also have the WASH component and then the food security and livelihood component coming together. So either I was mentioning earlier that the entry point usually of the targeted beneficiaries are from the health and nutrition activities, but sometimes we do identify the most vulnerable household within the community who will benefit from income generating activities or food security, and livelihood activities. And those vulnerable groups will be linked to our own services. So we try as much as possible to work to develop the multi-sectoral approaches, or working with local associations who do those activities, and then we do refer. And so, for example, I can see we do cooking demonstration. There is one question I can see now about the food ration, and then the psychoeducation or on the nutrition. So we do also cooking demonstration showing with the existing and available food or resources that exist. Then we do show, we do have those sessions with the participants to show how to cook differently with restricted resources.
Great, thank you so much. And we're at time. I'm just sorry about the crazy screen. I'm just flicking back to this page. So I just want to say a huge thank you to Ruth and Suan for presenting, and Karine, Meenakshi, and Ulzi for joining to help moderate and answer the questions. And thank you to all of the attendees for your active participation. We didn't get to all of the questions, unfortunately. I'm sorry about that. You were very engaged and had a lot of great questions. We hope that we can share those resources on on the webpage, and you can access the, see if some of the questions are answered there. Just a reminder that the recording and the slides and the resources that we listed will be linked on the MHPSS Collaborative's landing page for this webinar series. So don't forget to go there, and also a reminder that our next webinar in the Child and Family Thematic Group webinar series will be in April, and we'll be talking about the evidence and practice for integrating sport and MHPSS in emergency settings. So thank you very much again to everybody, and yeah, this was a great way to kick off the webinar series. Thanks again to the panelists and the attendees, and hope you have a good rest of your day or evening, wherever you're calling in from.